Good evening and welcome to tonight's virtual annual general meeting and annual members meeting, which our chair, David Walker, will officially open very shortly. My name's Sarah Taylor and I'm the Associate Director of the Communications team, which is supporting tonight's proceedings. We'd appreciate your patience and understanding if we encounter any technical glitches along the way, but we hope you'll stay with us throughout the evening and you can catch updates on our social media channels. There'll be plenty of opportunity to ask questions of our panellists when the time comes, and you can do so using the Q&A function on the top right-hand side of your screen. I believe we have a graphic here to show you exactly where to find it. So we do hope you'll enjoy this evening. I won't delay things any further. Just to make you aware that we do have easy read versions of all tonight's material available for you on our website. So now it just leaves me to hand over to David. I know he's keen to get underway, so over to you, David.
Thank you, Sarah, and can I add my welcome to Sarah's to this annual general meeting of Oxford Health NHS Foundation Trust. To governors, to members, to staff, directors, members of the public who may be attending. A lot of work has gone into preparing for this evening, so special thanks to Sarah and her team, and also to Kerry Rogers and corporate staff, but also, of course, to members of the Council of Governors who give so freely of their time and energy. Now, a bit of administrative business before we get going. We have a register of apologies, which you'll see noted. I'm not going to go through them now, that will be boring. And I hope too you'll have had a chance perhaps to glance at the minutes of our AGM last year. And I would imagine there aren't any amendments, but if there are, very important ones, signal them now. Trivial ones you could perhaps send through to the admin team and they will make changes as necessary. Is that okay? Good. Now, I'm shortly going to hand over to Chief Executive Dr. Nick Broughton, then for the presentation of the Trust's annual accounts to our Chief Finance Officer, and then we'll hear from the Trust's external auditors, Grant Thornton. I'd remind members of the Council of Governors that one of their statutory duties is to appoint our auditors and, as the name auditor implies, to listen to their views on how we've spent the money allocated and earned by us during the previous year. Now, I've had a chance to put down some written thoughts, so I'm going to be brief now. During the past year, the board has been reconstituted, renewed, and I hope re-energised. We've welcomed new executive as well as non-executive directors, and I'm confident that we have a team that's, you'll excuse the sporting metaphor, match fit, which it's going to need to be. The lack of rain in the summer was yet another sign and reminder of how much we need to do to make our lives and organisations more sustainable, emit less carbon. But during the months to come, we'll have to contend with inflation, spike in energy prices, massive imbalances in the public finances, prospect of recession, with all its consequences for the well-being, physical as well as mental, of our people. Meanwhile, none of today's pressures are going to abate. The shortfall in provision for children and adolescents, particularly mental health services, gaps in what we can offer to those on the spectrum of personality disorder, stretched out hours of community service, out of hours community services stretched, rehab beds immobilised because of blockages in social work assignments and social care placements. And we ask a lot of our clinicians, as we do of all our staff, but as their employer, we have to follow national norms and negotiations over pay and pensions, and so perhaps face their dismay and anger if they feel those negotiations are cut short or don't produce acceptable outcomes. All that said, I'd like to thank you, particularly members of the Council of Governors, for allowing me to continue to chair Oxford Health. It's a privilege to be part of and help to lead a tremendous group of people. My fellow board members, nurses, doctors, pharmacists, but also dentists, speech therapists, psychologists, and the finance team, our IT people, our gardeners, PAs, drivers, cleaners. It's a long list. Witnessing its diversity is another fascinating aspect of my job. I hope you'll see from the evidence presented this evening in the annual reports and accounts that our stewardship has been broadly sound. Over to you, Nick.
David, thank you for that, and good evening, everyone. Thank you very much for joining our annual members meeting. and obviously we're doing this virtually because of the ongoing challenges related to the COVID-19 pandemic. And it's fair to say that since our last annual members meeting, we have experienced considerable challenges across all the trust services. Like the year before, much of the past 12 months was spent dealing with the pandemic and managing both its direct and indirect consequences. In truth, this hampered our ability to deliver at times the care we aspire to, particularly in some of our inpatient settings where infection prevention control measures in combination with aging estate pose significant problems for our clinicians. And the impact of such challenges cannot be underestimated. Resilience on occasions may have weakened, but the resolve of our staff to do the very best for the people, both young and old, that they care for has not wavered. The well-being of our staff has remained an important priority for us. The intensity and volume of work has meant that more than ever we have had to strengthen our wellbeing offers, and we're working hard to limit the impact of the rising cost of living on colleagues. Our trust strategy is underpinned by a desire to be a great place to work and for colleagues across the organisation to feel valued, listened to and truly empowered. In recent weeks, our teams, particularly in out-of-hours services, mental health and community services, have been impacted by a national electronic record systems outage, which has hindered our ability to access and record patient information and maintain planned appointments. Few trusts across the country have been severely affected as we have, but thanks to a huge amount of effort, not least from colleagues in our information management and technology team, workarounds were deployed to maintain services. And we're hopeful that the patient care record system will be soon up and running once more, although full recovery from this will take a number of months. And in addition to all of this, we, like the rest of the nation, have mourned the passing of Her Majesty Queen Elizabeth II. She was a constant figure in our lives and epitomised many of the values that we hold most dear as an organisation, not least her sense of duty and commitment to public service. Books of condolence have been opened around the trust so that staff, patients and carers can pay their tributes. And I know that many patients and colleagues watched Monday's funeral and especially set up screens in day rooms across the organisation. Despite the challenges, we have achieved a huge amount, as the next slide hopefully shows. This infographic gives you a sense of the volume of care that we have delivered over the last 12 months. Patient contacts increased to almost 1.5 million, and we've treated literally tens of thousands of patients across mental health, community physical health, and dental services. In addition to this volume of work, there is much that we should be proud about, not least the key role the trust teams have continued to play in delivering the COVID vaccination programme. Next slide, please. In January this year, the former Prime Minister visited the Gutton Centre in Aylesbury to reiterate the national call to get boosted and to thank our teams for their tremendous work in helping vaccinate the population of Buckinghamshire, Oxfordshire and West Berkshire. Next slide, please. The delivery of 1 million jabs was marked as our large-scale vaccination centre at the Kassam Stadium in April. And as we head into the winter, our trust will continue to be the lead provider for vaccination centres across Buckinghamshire, Oxfordshire and Berkshire West. And our teams are already delivering booster jabs in those sites. Next slide, please. As David has indicated, teams across the trust have been strengthened during the course of the year through the recruitment of many diverse and talented new colleagues, reflecting our commitment to be an employer of choice and one that truly values diversity in all its many forms. I'm pleased to say that the executive team has been strengthened with 5 new colleagues: Carl Marlowe, our new Chief Medical Officer, Charmaine D'Souza, our new Chief People Officer, Grant MacDonald, our Executive Managing Director for Mental Health, Learning Disability and Autism Services, Emily Beige, our Executive Director for Strategy and Partnerships, and most recently Heather Smith, who you'll hear from in a couple of minutes, our new Chief Finance Officer. Next slide, please. In addition, the non-executive ranks have been strengthened by 5 new appointments: Sir Philip Rutnam, Andrea Young, Geraldine Cumberbatch, Professor Sir Rick Traynor, and Professor Cian Obrey. Next slide. We've also elected or re-elected 13 new governors to the Council of Governors, a body that continues to play a key role in leading our organisation. And the Trust membership has continued to grow. It's up nearly 6% from this time last year, a remarkable achievement given the challenges we've faced. Next slide, please. But staffing remains our greatest challenge. And with that in mind, I'm very pleased that we've been able to recruit 73 new international nurses who've joined the Trust from India, Nigeria, Ghana, Cameroon, Nepal, Kenya and Zimbabwe. These experienced nurses have been great additions to the Oxford Health team and are working on both our physical and mental health wards, and more are being recruited. The year has also seen considerable innovation and change as we continue to strive to improve the services we provide. Next slide, please. I'm very pleased that our 5-time Olympic gold medalist and Marlow resident Sir Steve Redgrave was able to open the Saffron House mental health hub in High Wycombe in November last year. It's a fantastic facility, and it was great that Sir Steve was able to spend a lot of time with the staff working there, who were clearly inspired by his interest in the services they provide. Building work has already begun for a new psychiatric intensive care unit for children and young people in Oxford, situated next to the Highfield unit on the Warneford site. And this 8-bedded facility will be the only NHS unit of its kind in the South East, therefore ensuring that young people are not placed out of area, miles away from their families and friends. Next slide, please. We've also submitted what I think is a really impressive application to renew funding for our Biomedical Research Centre, and this will hopefully ensure that we can significantly expand research in both mental health and community services. This application was led by Professor John Geddes, and we eagerly await the announcement of the results, which we hope to hear in the next few days. Linked to this, we've continued to develop our plans to build a new hospital on the Warneford site to sit alongside a research facility to help better link cutting-edge research with the delivery of mental health services. And so building on the model we have developed with colleagues from the University of Oxford in our Brain Health Centre. I also must mention the fact that integrated care boards became legal entities on the 1st of July this year. We are a key part of both the Buckinghamshire, Oxfordshire and Berkshire West system, and also the Bain, Swindon and Wiltshire system. As an organisation, we are absolutely committed to working collaboratively with all system partners as we help to shape a new future of joined up working with health and social care. The Trust must play a leading role as we develop more integrated approaches to delivering care, improving the health of the populations we serve and addressing the health inequalities evident in many of the communities that we serve. Our commitment to true partnership working is epitomised by Emily's appointment as our Executive Director for Strategy and Partnerships. And of course, Oxford Health is a combined trust that provides community physical health, primary care and dental services alongside mental health services. The year has seen important work to develop a new strategy for community services across Oxfordshire, as we look to ensure that the Trust's resources are used as effectively as possible to meet the needs of the population. And it's our Community Service Directorate that is now responsible for delivering the ongoing COVID booster programme. Next slide, please. During the year, we have seen the excellence of our services recognised and rewarded. The Hope Eating Disorder Provider Collaborative won Excellence in Mental Health at the NHS Parliamentary Awards this year, winning the backing of no less than 13 of our local members of Parliament. The Luther Street Medical Centre in Oxford was crowned winner of the Oxfordshire Health and Social Care Awards. The Vaughan Thomas team, based at the Warneford site, won 2 prizes at the Health Service Journal Partnerships Awards. And Oxford Health Forensic Recovery College was a finalist in this year's HSJ Patient Safety Awards. And we've just celebrated the first anniversary of our own in-house Exceptional People Awards for both teams and individuals. We've seen 24 winners recognised and 48 highly commended teams and individuals. Each was nominated by fellow staff or patients, and the monthly winners were selected by a panel featuring trust governors and executives. Next slide, please. Environmental sustainability has remained a key priority for the Trust, and we have continued to focus work on reducing our carbon footprint. The year saw the planting of a mini forest on the Littlemore site in conjunction with partners from Mini. It also saw our first electric vehicle charging ports being installed and the development of a green plan, along with green champions being appointed. But more needs to be, and indeed will be, done during the year ahead. What we have achieved has been through teamwork, and teamwork is very much part of the ethos of this organisation. And I'd like to thank many people who comprise the Oxford Health team, not least our non-executive directors and indeed my chairman, for their ongoing guidance and robust but always constructive challenge. I'd like to thank our Council of Governors, ably led by our lead governor, Mike Hobbs, for always striving to hold us to account as a leadership team and continuing expressing the views and concerns of the various constituencies they represent. I'd like to recognise the work of our various leagues of friends for what they do to support our community hospitals in particular. I'd like to thank our many volunteers and all those who've supported the Oxford Health charity, whose actions have made a real difference to the experience of patients across the Trust, whether it be through the development of wellbeing pods or the recent installation of an outdoor gymnasium for patients on the Littlemore site. And may I conclude by thanking colleagues across the organisation for their remarkable dedication and commitment to provide the best possible care to those who use our services during what has been and what continues to be an extraordinarily challenging time. It remains for me a great privilege to lead this organisation, and I look forward to what the next 12 months have in store. There will be challenges, I have no doubt, but I'm also confident that we will overcome those challenges working together. Thank you. And now I'd like to hand over to Heather, our new Chief Finance Officer, for a presentation of our annual accounts. Heather, over to you.
Thank you very much, Nick, and good evening, everyone. It's wonderful to meet so many of you virtually tonight. I'm Heather Smith. I'm the incoming Chief Finance Officer for Oxford Health. And just to introduce myself, 2022 has been a big year of change for me. I've left the civil service and joined the NHS. I've left London and moved to Oxford with my family, and I'm doing that because I'm really passionate about doing the job of Chief Finance Officer at Oxford Health. And I want to do this to help people and to make a difference in people's lives. So I'm going to start by talking a little bit about the year that has just gone and the accounts that we've just recently published. Finance should tell a story about what happens in an organisation, and I think these accounts do that. And then I'll talk a little bit about the future and the year ahead and some of the challenges and opportunities we face. And I guess just going into this, I'd say that for me, finance is a responsibility we all have for managing taxpayer resources and charge-payer resources efficiently and effectively. But also it's an opportunity, and it's an opportunity to support our people, to support patient outcomes and to reform the way we work. So I hope that these slides will be of interest to you all. So starting with the slide here that talks about the statement of comprehensive income, so the amount of money that we've received as a trust and the amount of money we've paid out over the course of this year. You can see in this how the year just gone, FY22, financial year 22, compares to the previous year. You'll see at the top that our level of income has increased over this period. That's because we've taken on new responsibilities, primarily for provider collaboratives like the Hope Collaborative that Nick referred to earlier, which means we get and spend more money than we did previously. We also achieved a surplus this year before our financing costs, and indeed we achieved a surplus after our financing costs of just over £4 million. So that is a great result for the year. I think it reflects the fact that we gained income related to COVID last year to support us through that. But in terms of timing, we gained it a little later than we'd have liked to in the year. So we weren't able to spend all of it that we would have wanted to. but we did deploy lots of that in supporting vaccinations and all the work we did for COVID. So it's great that we turned a small margin at the end of the year. If we could go to the next slide, please. This is a statement of financial position. So what many of us, sorry, the next slide, please, Katerina. I've missed one. There's one called Statement of Financial Position that came just before this. Here we go. Thank you. So it's all right. It's the next one. That's good. Next one. There we go. We've lost the heading, but it is still our Statement of Financial Position. It has the right numbers in it. This is what many of you probably would have referred to as a balance sheet for a long time. It tells you about the assets and the liabilities the trust holds. So it's a snapshot of our financial position and what we own at a point in time. You'll see that this year just gone compared to the previous year, the shape of what the trust owns is relatively similar. The biggest difference probably is that the change in the cash position, where the trust has gradually been building up a higher and higher cash balance in common with lots of organisations in the NHS. That's good news, but it also reflects areas where, for example, with the provider collaboratives, we've incurred income, we've gained money, but we haven't yet spent it. So we're carrying that expenditure forward to next year, and I expect to see that cash balance reducing again over the year ahead. Continue to the next slide, please, Katerina. So these are some of the key financial indicators of our performance that we publish in the annual report and accounts. So our working capital, that is a sort of slightly longer term measure of our liquidity and our cash balance. Our EBITDA, which is earnings before interest, tax, depreciation and amortization, and our adjusted financial position performance, which is that bottom line, £4.5 million. The area I probably draw out from this is the biggest variance compared to what other trusts would be spending of the same nature of us is the agency expenditure, which is high compared to other trusts, over £60 million. And that's something that Nick and the team and myself are all extremely focused on over the next year and the year ahead after that as well. In terms of capital, we delivered £11 million against our capital plan, so we're contributing a little back to the integrated care system there, and our better payment practice code has held up over the year, so that is broadly a good result that we're over 90% payment on time. Next slide, please, and last slide, please, Katerina. So just looking ahead, this current financial year, 22 to end of March 23, will be different. So we're moving away from the COVID-19 financial regime when the extra funding that we got to support us through COVID is reduced, and we've factored that into our plans on a reducing profile to reflect as those costs reduce. One of the things that will be different that both David and Nick have referred to is the way we work with the integrated care system. So since that came into existence in July, and also with predecessor organisations, that collaborative working with local providers is incredibly important in terms of prioritising what we do, and it brings together a lot of the commissioning for us in terms of what we are contracted to deliver. So as a trust, we work across a lot of ICSs, making our environment quite complex to manage compared to some trusts with smaller footprints. Our main financial responsibility, however, lies with what's called the BOB ICS, which is the Buckinghamshire, Oxfordshire and Berkshire West ICS, whose footprint almost entirely falls within our own, and which has a number of financial challenges. So we will be working with partners in that trust to make sure that we can meet demand and put resource where it's needed most. So just talking a bit about what this means for Oxford Health ourselves. So coming into financial year 22-23, we didn't receive the full funding for everything that we think was needed in terms of delivering the trust business. We have agreed a plan with the integrated care system, which is based on a £6.2 million deficit. That means it is expected that we will make that sort of deficit and that the trust will manage between us over the course of the year, whether that is the right outcome or not. but we are currently on track to achieve that level of spend compared to what we're funded for. That is good that we are on plan. We're efficient compared to other trusts. So RCI means a sort of relative cost index of 92. So if we were at 100, our costs would be relative to other trusts about exactly average. So 92 means we're quite a lot more efficient than the average trust because the amount of activity we deliver for our spend is high. Our cash position remains strong into this year. As I said, though, it should start declining over the year ahead as we deliver some of the spending we've deferred into this year. And I've mentioned the three provider collaboratives, the Secure Collaborative, the Children's Tier 4 mental health services, and adult eating disorders. We have got big capital plans again this year, so £15 million that are due, but there are tight limits over that, and I'm sure we could easily spend as much again. So we are managing that very closely and making sure that we meet all the controls around it. And we have a major capital project that's due for completion at the end of the year, around the end of the year, which is the new children's PICU unit that Nick showed you a picture of earlier. So overall, I think you know, the trust is in a really good place as we go into financial year 22-23. I passionately believe it's the job of everybody in the trust to help deliver against that, to manage the taxpayer resources well, and to secure those opportunities for best value out of it, and to support our people and support patient outcomes. So I'm really looking forward to working with everybody, both inside the trust and outside, to make that happen. I'm going to hand over now to Nick Coombe, who has led our financial audit this year from our outgoing auditors, Grant Thornton. And if I can say, as I hand over, that this is the last audit that Nick's going to be giving to us. But Grant Thornton are giving to us, I'd like to put on record our thanks to them for the brilliant work they've done for us over the years they've worked with Oxford Health. Nick, over to you.
Hello, everyone. Thank you very much for inviting me here to talk to you this evening. As Heather said, my name is Coombe. I'm representing Grant Thornton, who are the Trust's external auditors in respect of the year ended the 1st of March 2022. And I just want to give you an overview of the work we've conducted and the outcome thereof. So our work, as you can see on the slide, is two-pronged, if you like. On the one side, so the first point there is we consider the financial statements. We define an audit programme that enables us to conclude whether they are true and fair, and we'll consider in a little bit what that might mean, in order that we can form and express and give our audit opinion on those financial statements. And the second prong is to consider whether the trust has adequate arrangements in place to secure value for money. And again, I'll come back and talk about that more in a little while. Next slide, please. Firstly, the financial statements. So we follow a prescribed code that is given to us by the National Audit Office that we have to follow in terms of our audit programme, along with international standards on auditing, in order to reach our audit opinion report signed by not myself, the engagement lead, the director. So for you, that was Ian Murray. Unfortunately, he can't be here. He would usually be to you this evening. But what that report confirms is whether or not we believe the financial statements give a true and fair view of the financial position of the trust as at the year end, i.e. the statement of financial position, which Heather just talked to you about, as well as the income and expenditure activity that's taken place during the year, and which is the statement of comprehensive income that Heather showed you just a few slides ago. In addition to that, we're also required to consider the annual report and the annual governance statements. These, in my view, are really important documents for the trust, as it's a way they can tell their story for the year. Our responsibilities in relation to these documents are to check that they comply with the relevant guidance that's issued by NHS Improvement, and also that's consistent with our knowledge of the trust. We're also required to consider whether there are any uncertainties in relation to the going concern assumption. Now, it's a bit of a different concept for the private sector, which is all about having the wherewithal to pay your liabilities as and when they fall due. In the public sector, it's very much about the technical term is continuation of provision of service, i.e. whether the services provided by the trust will continue to be provided or not. So it's a very different set of criteria we're looking at, but nevertheless something we're required to consider. Next slide, please. In our audit of the financial statements, materiality is absolutely key, both to the preparation of the financial statements themselves as well as the audit process. Now, the technical auditing standards definition is there on the slide for you to read. In summary, it's the amount by which the users of the accounts would be influenced if there was an error or an omission in the accounts of magnitude. It is an art, not a science, in terms of what materiality we apply. There is judgment involved here. For 21-22, as you can see, it was set at 0.1 million, which is slightly higher than the prior year to reflect the higher level of income and expenditure activity. The eagle-eyed among you, when Heather showed you the statement of comprehensive income, will have seen that the income levels had gone up from under 430 million to over 550 million because of the increased provider collaborative activity, which I'm sure you're all aware of, and therefore our materiality increased slightly to take account of that. Next slide, please. So we use materiality, that figure we've just spoken about, to determine which particular areas of the financial statements attract most focused testing, but in reality there's very little that doesn't come under our scrutiny one way or another. In addition, there are areas where we apply even greater rigour because we deem that they carry a significant risk that it could be a material misstatement in there, and those are the 4 areas that you see in front of you. The 2 at the top, green boxes next to them, that's a red, amber, green rated. Green is that having done and delivered the audit work, we had identified no issues whatsoever. And the bottom 2, there were some minor issues, but nothing significant at all. You'll see in the description of 3 of those risks, the 3 bottom risks, that we have to consider. So with management override controls, that is the presumed risk that it exists in all audits, sector or industry. Revenue recognition, also a risk we have to consider. Improper expenditure recognition, as a public sector body, we also have to consider it for you. The one that isn't presumed is the one at the top. That's the valuation of property, plant and equipment, but we highlighted that as being a significant risk for us, attracting a significant amount of audit effort because it contains a big chunky estimate which is sensitive to changes and assumptions, and the trust's sort of property, plant and equipment value is just shy of 160 million. So it's a big figure and therefore worthy of our attention. Next slide, please. So this is the highlight really for the financial statements. What does that mean? It means giving you a clean bill of health. Yes, the accounts were true and fair, prepared in accordance with relevant accounting standards, and yes, they were prepared in accordance with relevant UK legislation. What I would say as well, we were pleased to report findings reports to Audit Committee back in June that the recommendations that we'd raised in previous years just had acted upon, particularly on areas of deferred income. So Heather spoke about that just now in terms of receiving cash due to COVID funding and then not quite spending it all. We'd made some recommendations for more stringent checks on that to be carried out, and I'm pleased to report that that had indeed taken place. Next slide, please. So this is our second prong. This is our value for money work. So again, our responsibilities and requirements here are prescribed by the National Audit Office, and we're specifically required to consider the 3 specified criteria there. So financial sustainability, governance, economy, efficiency, effectiveness, as well as any other risks of significant weakness we might identify. In the case of Oxford Health, we didn't identify any risks of significant weakness, so the Auditor's annual report that we provided gave on those 3 criteria alone. Next slide, please. Well, I've just mentioned the Auditor's annual report, and this is a very summarised version of what we reported there. So no significant weaknesses identified, which is a really positive outcome, though there were a handful of improvement recommendations made. The report is reflective of a point in time, and I think it's fair to say the NHS has been through an unprecedented set of years, and as it sort of transitions COVID into the new business as usual, Oxford Health has obviously got the new provider collaborative arrangements, which have increased very much in the 21-22 financial year, as well as the ICS is coming online more latterly. So the improvement recommendations we've identified shine a light on those areas we deem warranted, but I think it is worth noting that the Trust are self-aware, and the recommendations serve to add emphasis to the direction of travel that the Trust was already going in. Improvement recommendations are sort of the lowest severity of recommendations we can make, so if implemented, they should improve the arrangements in place, not indicative of significant weaknesses. So overall, positive outcome both for the value for money report and the financial statements. Thank you very much, and I think back to you, David.
Thank you very much. I should say to colleagues before we go on that we do keep a close eye on how we best organise meetings such as this, and obviously we have to keep an eye on the public health situation. We have mindful of sustainability, mindful of journeys that people make, mindful of venues that can accommodate large-scale meetings. We decided this year this was the optimal way of conducting the annual meeting, but obviously, we'll think again for next year and indeed for meetings of the Council of Governors in the period to come. Now, we've had a lot of information. You've hopefully had a chance perhaps before the meeting to look at the annual report and accounts. So this is the chance you now have to put some questions. I have a slight issue in that there are 2 Nicks on the panel. We have Nick, Chief Executive, and Nick, Auditor. And of course, Heather, our Chief Finance Officer. So you've got the question and answer function at the top of your screen, and hopefully you'll be able to put some questions, and Sarah Taylor will field them back to me.
Hi, David. Yes, we've got quite a few questions that are coming in. I will take them in order. A question here from an attendee asking, is it time for the Trust to consider adopting an Oxford living wage? Oxford being the most expensive place to live outside of London, and the cost of living difficulties that we're currently facing.
A very good contemporary question. I'm going to ask Heather if she wouldn't mind addressing this, because she's a recent transferee into the relatively high cost area of Oxford from the also high cost area of London. Heather.
Thanks, David. I'll talk about what we can and what we can't do. So in the NHS, we're bound by the agenda for change and the sort of pay scales that are given to us nationally by the NHS. We're not allowed to pay people anything different to what it says in those scales. And the additional living cost allowance that's made, the cost of living allowance, is provided to London, some of the areas nearby, but is not provided to Oxford. Now, that doesn't reflect what our people experience on the ground and living in such an expensive area, or travelling long distances in such an expensive area, and particularly with the sort of prices increasing the way they are. But there is nothing we can do to change that, you know, in the current circumstances. So we have to operate with the system that we have. I mean, what we try to do as a trust is think about what other ways there are to help. So there are changes that have already been made, for example, provision of free parking, provision of refreshments, attempts to support our colleagues with like information and advice and everything that we can think of to do to support people with the cost of living. but we can't unilaterally change the pay rates, unfortunately.
Sarah, what next?
The next one is on the issue of agency staffing, which we've heard a bit about tonight. So question, what are the trust plans around using agency staffing and how are we going to reduce the costs?
Nick, you referred to this question, which obviously comes up at virtually every meeting that we have of the board and its committees. What else can we say?
So this is an absolute priority for us as an executive team. There is a programme of work that Marie Crofts, in her capacity as our Chief Nursing Officer, is leading, looking at how we can improve quality and at the same time reduce agency. The programme to recruit our international nurses was part of this. It's gone well. As I indicated, we have further recruitment initiatives ongoing, including further international recruitment ongoing. We're also working very closely with other organisations in our local system. There's a piece of work that extends not just across the Buckinghamshire, Oxfordshire and Berkshire West system, but also into the Frimley and Surrey Heartland system, looking at a consistent working with agencies to standardise fees. But the other thing I would highlight is that we really do want Oxford Health to be an employer of choice. We want it to be a place that people want to work in and an organisation can retain the best staff. Central to that is offering people opportunities to progress their career, and we're well placed to do that through the learning and development offer that we have. It's also about getting the culture of the organisation right, ensuring that we are a place that values people, that engages people, that empowers people, no matter what their professional background or their seniority. And with that in mind, I am pleased that we bucked the national trend, being one of the few organisations that saw our overall level of staff engagement improve last year. Many organisations saw staff engagement deteriorate, but we didn't. It's not perfect, but it does indicate that we are doing certain things right, and we've got a big programme of organisational development work that Charmaine D'Souza, our Chief People Officer, is leading in conjunction with Joe Smart, one of her senior team, really to ensure that we have a great culture and that we are a place that people want to work in and want to stay working in. So various pieces of work, but it's an absolute priority for the executive team. And as David indicated, it's something that we are regularly held to account by the board, not least through the People and Leadership Committee that is chaired by Mindy Sawney, one of our non-executive directors.
Thank you. Sarah, what else have we got?
Well, we're staying on a bit of a theme here, David. We've also got a couple of questions which I believe conjoined. What is the trust doing to support those staff by the new pension arrangements? Other trusts, the author says, are being more supportive and coming up with practical support. No wonder people are going to agency working, they say. And coupled to that, trusts are being encouraged to use a retention premium to help with this. So why does Oxford Health not do this?
Those are quite detailed questions. I don't know if either Heather or Nick are on top of. I mean, NHS pensions are hugely complex. Any light you might be able to shed on that, Nick?
So shall I kick off, and Heather may want to chip in, David. So picking up the retention premiums or recruitment premiums, that is something that we have used in certain services. Being frank, it hasn't proven to be particularly effective. But it's something that we continuously review, and that's because we don't want to be an outlier. We want to be able to offer the best possible terms we can to our colleagues across the organisation, but we also want to work in partnership with other local trusts, so we avoid an arms race developing, which is a risk here. In terms of pensions, I'm not aware that there are organisations doing more than we are. It would be good if the person who posed that question could perhaps drop me an email and include Charmaine in that, because as always we are open-minded and we're keen to learn from other organisations, not least those sort of outside the BOB and BSW systems, to see what more we can do. We are very aware that this is a very challenging period for people. We are acutely aware of the impact of the increasing cost of living on colleagues, and as I've said repeatedly, verbally and in writing, we are committed to doing all we can to address this problem and support people as much as we can.
Thank you. Sarah.
A couple of other questions here to do with the staffing crisis that it's described in the media, the staffing crisis. What are we doing about it, and how is the Trust addressing the shortage of doctors?
There's another one, I'm afraid, Nick. As the doctor, over to you.
So there are about 135,000 vacancies across the NHS as of today. This is a national problem. The origins go back many years in terms of the number of people we have been training to become nurses, to become doctors, to become AHPs, to become psychologists, etc. I would reiterate what I said earlier about us wanting to be an employer of choice, rather, and the sort of organisation that people are queuing up to join. Now, there's some work to do before we get to that point. There's a lot we're doing in relation to medical staffing, not least we've recently strengthened our medical staffing function and have looked at how we can enhance our approach to recruiting medics and doing this in a far more targeted way. Later this month you will see in the British Medical Journal a revised approach to how we advertise posts across the organisation, but we're not just advertising in a BMJ, we're looking at various other channels to attract talent to the organisation. We're working closely with the LNC, so that's the Local Negotiating Committee of the BMA. We've looked to strengthen our Medical Advisory Committee, which meets again tomorrow. We've got 2 new chairs chairing that group, which is a means by which the consultants and indeed the wider medical body can influence what's going on in the organisation. Our Chief Medical Officer, Carl Marlowe, is organising a conference for medics later this year. Big focus of that will be medical engagement and what we can do to ensure that the medics feel truly engaged and empowered across the organisation. And linked to that, it's about creating job plans that are attractive. It's very clear that consultants and other career grade doctors don't just want to be doing clinical work continuously 9 to 5 days a week. They want interesting, varied job plans, whether that be including research, teaching, leadership, other activities, and that's something that we're looking to do to ensure that people have got protected time to do things which they find suitably stimulating, which make the jobs attractive and not just attract new talent to the organisation, but retain the talent we already have.
Thanks. Now we have a few minutes left for further questions. Sarah, what's on your list?
Well, we have there's a lot of questions coming in about pay, as one might expect, but I think we've covered that. Perhaps one area that I'd like to cover is something that Nick alluded to earlier in his opening remarks, which was around the clinical systems outage. And I believe this question has come from one of our governors in terms of reports in the HSJ today. Could we give some clarification about, could we confirm rather, as reported in the HSJ, that patient information hasn't been accessed or lost as a result of the recent attack on electronic patient records?
Nick?
So I'm not aware that there is any evidence to indicate that patient information is being compromised. Clearly this is a complex issue, and it's one we are keeping a very close eye on through Martin Ward, who's the Executive Director responsible for IMT, and other colleagues. We have regular meetings across the organisation looking at this. We're working closely with the supplier of the electronic record system and indeed with the national team. It's possible the situation may change, but the latest update I have is that there is no evidence to indicate any compromising of patient information.
Thank you.
Have we got time for?
We do,
Sarah.
David. We've got a couple of more questions that I feel we might be able to answer. One is around what are we doing to reduce waits for our patients. Some of our services have got tremendous waits. What are we doing to address these? I think perhaps this might be in relation to CAM services.
Again, a subject which preoccupies the board, but Nick, perhaps you could say something about that.
Yeah, so we do have some significant waiting lists for some of our services. I'm thinking in particular of assessments for children with potential neurodevelopmental conditions of one kind or another. Again, this is a national problem, unfortunately. What are we doing? Well, we're working very closely with other organisations, not just within the system that is Buckinghamshire, Oxfordshire and Berkshire West and the BSW system, but also with the entire South East region, looking at how we can identify best practice from other organisations and roll that out at scale. We're looking to how we can use digital solutions more effectively and at a larger scale than we have done previously. There are some digital platforms that have proven to be fairly effective to address some of these challenges, but not all. And one of the positives from the COVID experience was that we were able to adopt certain digital approaches and roll those out pretty rapidly. Some of the waiting lists are related to staffing challenges, which we've touched on already. But the other thing I would say is that it's clear that sometimes some of the ways we do things are not as efficient as they could be. And that's why one of the things that we are totally focused on developing across the organisation is a strong culture of quality improvement. We've got a quality improvement team that's been extended and expanded in recent times. We've got in the region of 100 quality improvement initiatives ongoing across the organisation, extending across the full breadth of our services, not just clinical services, but also some of the support services or so-called back office services, looking at how we can use the limited resources we have as efficiently and productively as possible, and how we can reduce waste as much as we can. So there's a range of stuff ongoing. Some of the problems we face are undoubtedly national challenges. Some are related to staffing, which we've already touched on, and other things are related to our own internal processes, which we are constantly looking at and trying to improve.
Thank you. Now, Nick, Auditor Nick, it just shows you if you issue a clean audit opinion, you get no questions. This may be an incentive, I hope, a disincentive to issue clean audit opinions where they're not justified. Sarah, perhaps we've got a few minutes left. What would you call next?
We do. I have a question which is one of finance, which will probably be best served by Heather rather than Nick.
I'm rather hoping so, Sarah.
Yeah. So we're going to move on now to mileage rates. A person here has posted claiming that other trusts are paying more in mileage. I know ours went up, but it still doesn't cover the mileage car upkeep for those who are travelling each day to provide the best care. And this person feels that the mileage rate needs to be re-evaluated again. I wonder if Heather might be able to.
Thanks, Sarah. This is something we watch very closely, and we are comparing what we do to other trusts. As Nick said, it's our desire to be an employer of choice and to use what flexibility we can to support people. So we look at mileage. Recently, we look at it regularly. If there's a particular trust that the question has in mind, please feel free to drop me an email to draw my attention to it. And I'll share that with our Chief People Officer as well. So thank you.
Right. How are we doing for time?
We still have a few more minutes, David. I'm afraid to.
No, good. This is the point.
So
one of the purposes of the meeting is. So, question next.
Next question. What about job plans for other disciplines, especially nurses, as our retention plans as our retention plans or strategy does not seem to retain frontline junior staff, which is where the risk is greatest.
Junior
staff, frontline junior staff. So one might presume this might be healthcare assistants and those entering into a clinic.
I mean, obviously you've talked a bit about the retention, Nick, and what else can we say?
Yeah, so I think I would dispute what's just been said in that, I've met many colleagues across the organisation who joined us in very junior roles and have progressed up the ranks as a consequence of the training opportunities that were available across the organisation. Now, clearly that doesn't always happen, and it's disappointing when it does not. But as I said earlier, we're very keen to extend these opportunities to develop people and ensure that they can fulfil their full potential whilst working in Oxford Health. And one of the great strengths of the organisation is the scale and the fact that we deliver so many different services across such a broad geography. It does mean there's lots of opportunities for people to grow and develop their skill set and progress their careers. I'd also highlight that Marie, who I mentioned earlier, our chief nurse, will be launching a new nursing strategy in a couple of weeks, which is very much focused on how we can develop and strengthen the nursing workforce and create opportunities for nurses. But there are examples of that already, as I said, whether it be nursing associates and other people who join the organisation and then have opportunities to gain qualifications, become fully qualified nurses, and then become quite senior nurses. So yeah, watch out for the nursing strategy. I think it will reflect our absolute commitment to address the point you've made.
Sarah.
Thank you very much. I have some questions now around our green and sustainability plans, which I know is something that is one of our key priorities. Question from an attendee here. What are our future plans about becoming a more greener trust in the months and years ahead?
So we have many, as I mentioned.
I was going to say, having attended a meeting last week of the Oxford Zero Carbon Partnership, I was just going to say one or two things, but I'm happy to follow you, Nick.
Well, I suppose I was just going to highlight that we published the Green Plan. We're working very closely with other partner organisations, both within the NHS and in the private sector. We see the opportunities from the pandemic experience to rationalise our estate, to move towards more flexible models of working, to use digital remote solutions, this meeting being a case in point, which will allow us to significantly reduce our carbon footprint. We're also looking to enhance and extend our green spaces to make them truly therapeutic spaces, and the mini forest I referenced earlier is a great example of that. Looking at converting all our fleet to electric vehicles, increasing the number of electrical charging points that we have, encouraging colleagues to use other means to get to work as opposed to their car, make it easier for them to cycle to work, for example. A whole range of initiatives, and being a sustainable organisation is one of our 4 key strategic priorities. So it is something that we take very seriously, but as I said in my opening address, whilst we have made significant progress, there is more that we need to do, and indeed will be doing during the course of the next 12 months. But David, back to you.
No, I was just going to, I mean, any practical suggestions colleagues might have would be entirely welcome. At this meeting with the Oxfordshire County Council and the City Council, we talked, particularly thinking of Oxford, of solar panels on buildings, energy generation on site, using park and ride as a hub, and perhaps providing electric bikes to allow staff to drive to a park and ride and then use the bike to access our sites within the city boundaries. We've obviously talked a lot about transport for our district nurses within the city and within the county, and how they best get about sustainably. So you know, there are lots of things going on, but we can, as I said, always add to the list of things that we can do practically to change the way that we do move about and generate energy. Sarah.
Well, David, I think that brings us to the end of our questions in this segment. So it's back to you then for the...
Sarah, if I may, can I just come in with one final thing, just pick up what David said about cycling, for example. We have recently extended our Cycle to Work initiative, which now allows people to buy electric bikes, because we know there's quite a interest in using electric bikes, and I know a couple of executive colleagues have either already purchased them or about to purchase them. So again, I think that is an example of our commitment to reduce the carbon footprint and do all we can to become a truly sustainable organisation.
Now, colleagues, this would be a sort of rather dry meeting if all we did was talk about the annual report and accounts, as important as they are. So we thought what we do in what we've got left this evening, the time we've got left, was to look in little detail at some of our services to allow you to sort of learn a bit more perhaps and ask questions as you feel necessary about them. So we've looked at 3 areas. The first up is our mental health work in Oxfordshire, Bath, Swindon and Wiltshire. Katrina Anderson is going to introduce a video on the Keystone Mental Health and Wellbeing Hubs, and she'll be joined for a question and answer session after that with Debbie Walton, Head of Adult and Older Adult Mental Health Services for Oxfordshire. In a second segment after that, we're going to look at one of the provider collaboratives that you've heard about already this evening. This is the CAMS Tier 4 Thames Valley Collaborative, which tries best to deliver care and help quicker recovery for vulnerable young people in our area, in collaboration with partners that you'll hear about. And that conversation will be led by Clinical Director for the collaborative, Gillian Coombe. First of all, though, over to Katrina Anderson.
Thank you, David, and thank you very much for giving us the opportunity to present some of our innovations and service developments across Oxfordshire. We're going to be concentrating on Oxfordshire particularly this evening, and our implementation of the community mental health framework. We have a video for you, which I'll introduce in a minute. The Bob ICB applied for and was awarded 3 years of transformation funding, and in Oxfordshire we will be using that transformation funding to develop and implement our vision for community mental health framework, which we are seeing as a transformation approach to how we deliver particularly our community mental health services. We very much developed the model as a co-production piece in consultation and partnership with service users, carers, the voluntary sector and with primary care colleagues. And we very much listened to feedback from service users about perceived gaps in services and actual gaps in services, which has resulted sometimes, unfortunately, in some service users feeling that they've had to reach crisis point before they can receive the mental health services that they need. That's obviously not what we want to be doing. Our method of delivery will be via primary care mental health teams and via community mental health hubs on the high street. You'll hear more about those in the video that's to follow. Thank you.
Well, perhaps Katrina could just give us a brief intro so that the first few minutes can be taken as read, as it were.
I'll do my best, David. I might ask Debbie Walton to help me. She's much closer to the detail than I am. As I said, we're using the transformation funding to develop and implement our vision for delivering the community mental health framework, which is essentially about delivering care much closer to home. That's our vision for Oxfordshire, delivering care, mental health care to people via what we're calling a hub on the high street and via primary care mental health teams, which means we hope that service users will be able to access mental health services at an earlier point in their mental health journey. We'll be very much focusing on early intervention and prevention, and people will be able to hopefully further down the line self-refer through the hubs. And we're developing a number of pathways that we will be delivering in partnership with voluntary sector organisations, for example, an organisation called Elmore, who will be helping us and supporting service users with personality disorder. We also have a number of peer support workers who will be working within the hubs, alongside our team of professionals providing the primary care mental health teams.
Debbie, do you want to? I think the concept of the mental health framework is new to some people. Perhaps you might say a few words about the background to this this innovation, which the aim of which is perhaps to reduce the number of people who are inpatients for the sake of better care in a community or a home setting. Is that right?
Thank you, David. Yes, that's correct. So we know, and the whole purpose of this framework from NHS England has been really about closing the gap that we know exists between kind of primary care and secondary care, and people with serious mental illness really having to, or telling us, so a lot of this, as Katrina mentioned earlier, we've done a lot of co-production, we've done a lot of work meeting with people with lived experience who tell us that, you know, they often have to put themselves at risk to get access to our secondary care services, which isn't what we want. So we really are looking at those early interventions when people start to experience signs of mental illness, or people who maybe have a diagnosed serious mental illness but start to relapse. So really having that intervention earlier in the community, close to where people live, is the real point of the work that we're doing. And the idea of the high street and the health on the high street is that it takes away the stigma of walking into a mental health building and actually just accessing on the high street.
Well, if you don't, this question to you, Debbie, what in the longer run might this mean for the distribution of our clinical staff? Would it mean perhaps people moving into more community focused positions than they have at the moment? Our psychiatrists, our psychologists, our nurses?
Absolutely. So we are currently recruiting into the hubs psychological therapists, assistant psychologists, nurses, occupational therapists, peer support workers, employment support workers, and our voluntary sector partners. But yes, the expectation will be that the pressure is removed so much from our current adult and older adult mental health services, which helps us then reduce the waiting times and really give staff in our current services who are constantly under pressure to have the time to really work in a co-produced way with patients to deliver the interventions, the nice recognised interventions that we hope and expect that mental health services can provide. So really, we will then hope that that reduction means that we can move staff between teams and experiences, so really working across the integrated community mental health pathway, which does include that primary care team, secondary care teams, and the sort of specialist services, complex needs, psychotherapy, etc.
Sarah, do we have any questions on the community mental health framework that we could pick up before we move on?
Can I just add to just something that Debbie's just said, David, if you don't mind?
Go ahead, yeah.
I just wanted to just say that we're already starting to see a reduction in inappropriate, or indeed in referrals to our adult mental health teams, because they're being picked up in primary care in a much more appropriate way, which, as Debbie said, is relieving some of the pressure on our adult mental health teams, enabling them to be able to provide the specialist secondary interventions that we need them to. So we're already starting to see an impact. So we'll be hopeful that will increase over time, and evidence from other areas shows that it will do, which will enable us to redeploy our resources where they're needed.
So Sarah, any questions on that one before we move on?
We have got a few questions coming in. There's one here, David, from Julian Fitzgerald. Would the hubs be roughly based along the lines of old NHS walk-in centres?
Debbie?
To a degree. So the high street model that we're looking at is the entry point of the shops that we're taking over predominantly will be run by a social enterprise. And then we will have the capacity to run groups and have other organisations, which I think I haven't mentioned, like the Veteran Service, Age UK, and other partner organisations working within the hubs as well. But yes, we aim initially, when we open the first 3 hubs over the next couple of months, referral will only be from GPs initially, but within quite a short time frame, we hope, with sort of 3 months after that, we hope to be able to offer a walk-in self-referral service as well.
Thank you. The time is pressing, I'm afraid. So apologies to colleagues for technical issues. Katrina, you were going to introduce the presentation we're going to see about the collaborative. Is that right?
Yes, David, thank you. Oxford Health started commissioning child and adolescent mental health services in 2019. We formed a provider collaborative with our partners Berkshire Healthcare, Gloucestershire Healthcare and Active Care. We became full commissioners of child and adolescent mental health services across the Thames Valley in April 2021, with Oxford Health being the lead provider. In addition to the range of inpatient care that we offer to children and young people, we've also developed an innovative and exciting model of being able to provide hospital level care to people in their own home via a virtual platform. And that's particularly for children and young people with eating disorders. And it's proved to be very popular and very successful, and it enables us to deliver a level of treatment to children and young people in their own homes, preventing hospital admission and enabling recovery in a more proactive and community focused way, as I said, to prevent young people being moved away from their home, and it engages the family as well. And building on that, we're looking at rolling that out to other children and young people. We do have a video which explains that in more detail if we're able to show it.
We'll try.
We'll try our best. So let's give it a go.
Only the most unwell young people require treatment in a child and adolescent mental health service hospital, and there haven't been enough beds across the country. So Oxford Health got the opportunity to become commissioners of inpatient services across the Thames Valley, and we were really excited to lead this project along with our partners Berkshire and Gloucestershire Trust, along with Active Care as an independent sector provider. This has meant that we can improve quality of care for young people in inpatient settings, but it also means that we can be in charge of our budget and reinvest in new and innovative services. The first thing that we decided to do was try and prioritise getting the right children in the right beds. So we wanted young people closer to home, closer to their families, closer to their local community teams, because obviously that's better for them, but it also means that they've got less time in hospital overall. So we got the number of young people down from 25 originally to just 5 young people today who are not placed within our network, and obviously we want to get that to 0. It's important that young people are nearer to their families so that they can have their families visit more often. It also means that they've got closer links with their friends and their communities. But the other thing is that they're nearer to their local community teams, which means that people who work in the community teams can go in and continue some of the work in the local inpatient units. And the inpatient units have got much better relationships with the community teams. And we've shown that by having young people placed closer to home, their length of stay in hospital is reduced by about 10%, so they get out of hospital quicker as well. The other thing we're doing is investing in services to try and keep young people out of hospital. Last year we started a pilot project called Hospital at Home for young people with eating disorders. So this is a project which uses Microsoft Teams to deliver virtual care to young people, and it means that the families are looking after the young people in their homes with lots of coaching from the therapeutic team. Now that we've shown that the hospital at home model for young people with eating disorders has been so successful, we wanted to build on this, and often young people who are autistic or have moderate or severe learning disabilities have been cared for far away from home because we haven't had those specialist inpatient beds in our network. So we're now building a service to launch in the autumn, which will mean that young people will be treated with a hospital level of service, but either in their home or residential setting.
Excellent. Sarah, do we have time for any Q&A, or do we need to move on?
I think, in all honesty, David, we need to move on.
Right.
There are some questions, but we can perhaps.
Well, the questions we can do our best to pick up outside, but we have a full agenda, I'm afraid. So, with apologies, we do need to move on, because in that space between primary care and the acute sector in Oxfordshire lies community services, and exciting things are happening. Exciting thoughts are being thought. Ben Riley.
Well, good evening, everyone, and thank you very much for your time tonight. I'd like to start, if I may, by thanking my directorate leadership team, all our clinical and operational leads and heads, and all the many dedicated staff who work in our primary, community and dental care services for their incredible efforts again over the past year. The year has been something of an obstacle course in terms of the barrage of challenges we've faced over time, from heat waves to IT outages and the ongoing pandemic, of course. But our staff have again shown tremendous reserves of energy, commitment and enthusiasm in the valuable work that they do to improve people's health and well-being, whether that's been changing personal plans at short notice to work additional shifts, or volunteering in terms of crisis to support our services at weekends and so on, and all the while just keeping calm and carrying on. As a result of all this hard work, the Directorate's not only managed to produce and provide its long-standing services, but also grown to provide a wider range than ever before, really, including our thriving dental care partnership that we've founded with West Berkshire and Central and North West London NHS trusts that serves patients across the Thames Valley, as well as the COVID vaccination services we provide across the Buckinghamshire, Oxfordshire and West Berkshire areas. And we've continued to provide a full range of primary and community care services for both adults and children in Oxfordshire, which range from the planned care that we provide to prevent and manage long-term illness, through to the urgent response services that older people need when they become ill and when they need rehabilitation and recovery after that. Next slide, please. So this just gives you an overview of the range of services that we now provide in the Directorate, many of which that I've just covered there, really. Can we move on to the next slide as well, please? So in recent times, a lot of focus has fallen in the media on urgent care services, which are tasked with treating a growing population of older people and reducing their risk of admission to hospital. And you can see here some facts and figures showing how busy we've been in Oxfordshire. This shows the large volume of urgent care that we now provide in our GP out of hours services, our minor injuries and first aid services, and district community nursing and therapy teams, and urgent community response and ambulatory care teams, which we'll hear a little bit more about later. Plus, there are many other teams of services that I can't mention here that contribute to this big group effort. Next slide, please. So as well as continuing to provide our everyday services, if you like, we've progressed a large amount of work on the strategy that we're developing, and some key examples are presented here on the slide. To pick out just a few, in addition to our dental care partnership that I mentioned, we've launched a new urgent and community care provider collaborative for Oxfordshire in partnership with our colleagues at Oxford University Hospitals. We've also launched some new specialist inpatient beds with our community hospitals for people at the end of life, and that's in partnership with the Sue Ryder charity. And I'm delighted to say that our community hospital leadership team has recently won a Community Hospital Association National Award for Innovation and Best Practice. The areas of work set out in this table relate mostly to our community services for adults, but we're also prioritising plans to respond to the increasing level of need experienced by our vulnerable children and families, such as the increasing need for speech and language therapy, safeguarding support, and specialised care for the record number of unaccompanied asylum seeker children and children moving into care that we've seen over the past 12 months. We've also been part of a successful pilot service with our colleagues at OUH to enable more children with acute illness to receive care at home following an attendance at hospital. Next slide, please. In terms of how we're approaching our strategic development work, both for children and adult services, we've adapted the Trust strategic framework with the 4 domains shown here so that we can think about them in the context of primary, community and dental care services. Next slide. Thanks. So thinking about quality, as a trust, we're committed to delivering the best possible care and health outcomes for patients and families, but we do recognise that we can't do this alone, and we must work with an increasing range of healthcare partners. And one way we're doing this is through the development of collaborations and shared services such as virtual wards, and by strengthening integration with social care and voluntary sector services such as Age UK and some of the others that I've already mentioned. Next slide, please. We also want to make our directorate a great place for everybody to work, and we want to support our staff to maximise their potential, develop long-term careers with the trust, and develop a positive and just culture, really. We also want to increase the training and the apprenticeship opportunities that we provide and review how we can improve our skill mix to best meet the patient need that we need to meet. Next slide, please. We need to make the best use of our resources and protect the environment as well, and this includes our financial resources, as we heard, and our physical resources like buildings, as well as the transport and the energy issues that we've already discussed here in the meeting. This means working with our health and care partners to reduce duplication and work more efficiently. And one of the ways that we'll do this is through the rollout of a new electronic record system that will enable us to share information about parents more easily, including with staff who work in general practices. Next slide, please. Research is the next area of the strategy, and we've got a great opportunity, especially in and around Oxford, to develop our trust as a centre of excellence for research and innovation to improve the health outcomes of our partners both now and in the future. And we're working closely with the Trust's R&D and the quality improvement teams to develop opportunities for more staff to participate in these areas of work as integral parts of their role. And we're also keen to empower staff to innovate in our services and to engage positively with patients and carers in this innovation work. And speaking of patient engagement and innovation, to finish this presentation, I'd like to share with you a video of one of our patients describing her experience of our innovative 2-hour urgent community response service, which visits patients who are experiencing a health or care crisis, enabling them to receive more medical, nursing or therapy treatments at home without the need to go into hospital as they might have needed to do in the past. So in the following video, Antoinette Broad, our clinical lead for the intensive community care pathway, will explain more about what the service can provide. So we'll play the video now to end the presentation, and I'll be happy to answer any questions that you might have. Thank you.
So as we get older, we become unwell, and our ability to compensate and recover can be more difficult. And without immediate and fast intervention, often people can be admitted to an acute hospital. We know that being in an acute hospital can increase our risk of infection, it can reduce our mobility, and we also know from public feedback that nobody wants to go to hospital. They much prefer to stay at home, around their family, friends, and in a familiar environment. Urgent Community Response aims to do just that. We step in to see people within 2 hours or 2 days, if less urgent. Our 2-hour response advanced practitioners work alongside other clinicians, families, caregivers, and the individual to agree a way forward together to provide the right care and intervention to enable them to receive their care at home. So they assess patients in their own home. It reduces the need to call out an ambulance, reduces the need to transfer to hospital, and it's unquestionably a better experience for the patient and their families. In addition, it reduces delays to treatment. Just have a listen to Elizabeth's story. She'll talk through her experience following a visit, and it demonstrates how we interface with other services to provide the support for her to stay at home.
Turned too quick, or I know I didn't faint.
I think you overbalanced.
I overbalanced and I hit both the glass doors and I ended up sitting in the shower. We got the buzzer. You press that first.
And they got the ambulance.
That's right. They wanted me to go to hospital and I said, sorry, I don't want to go. The nurse came with a carer. And she had ever such a lot of writing to do.
She was here 3 hours, give you a real check over medically, you know.
I had
blood sugar.
Blood sugar, because I've got diabetes. Yeah, they were really thorough.
Two nice people.
Two nice people.
Highly recommend them.
Oh, definitely. If you can, you know, they're really good.
Sunday evening, she rang me. She said, I'm going to go and bring the doctor in the morning. 8:30, she rang me. She's made an appointment for us to go to the doctor that day.
Amazing.
Furthest you to age.
Oh, yeah,
age UK, and the Falls Clinic.
The Falls Clinic.
So we're just waiting to hear from them. They was brilliant.
They were brilliant.
They couldn't have done more. Anymore.
It was wonderful.
Yeah, very thorough.
Yeah, it was great.
Sarah, have we got time for any questions on community, or do we need to move on?
I think we can do a couple, David, if I may. The UCR question here, the UCR service sounds wonderful. Are you going to expand it so more people can be treated at home?
Yes is the short answer to that one. It's really a core part of the strategy, I think, and there's definitely a move towards treating more people in the home as we can, because we do know that that increases their long-term independence and health outcomes. And as we just heard in the clip, it's very much what people would prefer, if at all possible. And as the technology improves and our sort of understanding of the potential for what we can do at home increases, there's more and more opportunity to do that, I think. Our biggest challenge is going to be finding the resources to enable us to meet our ambitions there, I think, but we're working on it as best we can.
Another question?
Yeah, we have a couple more, David. Can we give examples of some of the changes we're making in community services that will help increase independence?
Yeah, well, absolutely. So that's one of them, really. So keeping people at home, we actually stop them from deconditioning in sort of medical jargon and so on, and losing their mobility, their independence and their confidence. So we find that one of the big things is re-abling people to get back to their usual way of life after they've had an episode of acute illness or been admitted to hospital. And that's a really important part of it. And we know from the evidence that we've got and what we see they say in our services, that if we can do more of that care in people's homes, we actually increase their independence and the better long-term outcomes. And that's often a bit counterintuitive to what people used to think in the past, where it was often thought the best, safest place to be is sort of tucked up in a hospital bed. But we know if you get old and frail, that's actually often not the case. And so we need to sort of, move as many sort of services in that direction as we can, while also making sure that people are safe and get the care that they need.
And a final one, David, if we may. How are the new specialist beds within our community hospitals helping us to better meet our patient needs?
So I mentioned briefly in passing that we've built some sort of specialist beds for end of life care, and partly that was also responding to changes in other services that were in the south of the county with closures of hospices and so on. But also it's recognised that that's the sort of group of patients that we see in community hospitals where there is some sort of specialist knowledge and expertise needed to best manage their care, particularly for people with more complex home situations, for example. And by putting those beds in, we're able to provide a very specialist service for particular people, but also it spreads that expertise and learning throughout the rest of our community hospitals and wider services as well. The other area that we're working on at the moment is bariatric care for plus size people who also have a particular set of needs, and this is something that we're developing in Witney Community Hospital, for example. And I see that that's probably one of the directions that we'll take community hospitals in the future, in terms of specialising in certain areas, because there are sorts of groups of patients out there that have particular needs.
That's great, Ben. Many thanks for that. You mentioned your desire for community services to take a full part in research, and earlier this evening, Nick mentioned the broad ambition that this trust has to be a trust that bases its medical practice in evidence, and also to seek to extend that evidence base by being a very active participant in extending knowledge through research. And obviously our situation adjacent to the University of Oxford and Oxford Brookes gives us the potential to be much more of a leader in research than we are, although already we are distinguished among mental health and community trusts in the country by having a large research domain, about which we have a few minutes to hear about from Professor Vanessa Raymont, who is our Director of Research and Development. Vanessa.
Thank you very much, David. And you inadvertently promoted me there. I am a doctor. But thank you nevertheless for considering I could be a professor. So good evening, everybody. Really nice to be here. And as we've just said, and Ben reiterated, one of the key aims for us as a trust is to become a leader in research. And so I'm going to give you a summary of R&D achievements over the last year and some details about what we hope to achieve in the future. If I can have the next slide, please. Okay, well, we're just waiting for the slide deck to load up, which I'm sure, there we go. Right, so this is the slide I wanted to talk about. So I wanted to start with a few comments about why I think research is particularly vital and an exciting area of development at this time. So there's been quite a lot of announcements from our government over the last couple of years about how the UK can use research to tackle key healthcare questions and problems that we all face as effectively as we did during the COVID pandemic. So I think we're all very aware of the successes that we had in Oxford, particularly around developing vaccines. And we can learn lessons from those and think about how we can use research to develop further improvements in services. And one of the key strategies the government has announced is something called the Life Sciences Strategy. And that's a 10-year plan which has 7 themes. Again, about healthcare issues that need to be tackled over the next 10 years. And 3 of these are mental health, dementia and aging well. So areas that are very much important to us as a trust. And I think this provides incredible opportunities for us to further research to eventually further better services for patients. And on the right, I've got a picture here because actually Boris Johnson, just before he left us as Prime Minister, announced something called the Dementia Mission. And this was actually also named Babs Army after Barbara Windsor in the picture there. And so again, this is another key piece of funding that's coming through from central government that's going to really allow us to progress research to a great degree. And so based on that, I'm really pleased to say that 2 key pieces of infrastructure for research within Oxford Health that are actually funded by NIHR, which is our main source of government funding for research. And one of those is the clinical research facility, so our Oxford Cognitive Clinical Research Facility. And this is a facility where we do a lot of the assessments, interviews with participants who come into our research studies. And that was renewed for another 5 years in February this year, with just over £4 million being awarded. And that sounds like a lot of money, but this research facility does a huge amount of work and is actually the only mental health dedicated CRF in the country. And it really reflects all the great work that staff there have been doing over the last 10 years. Another bit of our research infrastructure within the trust that was renewed this year was our Biomedical Research Centre. And this is one of 20 centres across the UK. And again, we are unique in Oxford that we actually have 2 BRCs, and that means we have one sitting within our own mental health and community trust. And that's just been renewed for another 5 years. And this is another vital element as it supports a lot of key staff and new projects in research. And one project that the BRC has supported that we'll hear about shortly in a video is the Game Change virtual reality programme, which is actually the largest ever trial of the use of virtual reality in mental health. Next slide, please. I'd also like to highlight some progress with something called Count Me In. Now, this was an initiative that has been in place since August last year. And what it means is that all patients who come through the trust in whatever form are informed that as we are striving to be a very research active trust, they can be contacted about research studies they could be suitable for. And as a result, over 22,000 people can now be contacted. And just to give you a sense of the achievement of this compares to just over 2,000 people that were able to be contacted before we brought in this system. Reassuringly, although people are given the option to opt out so that they don't receive information about research studies, only 368 people have opted out since August last year. Following on from this, researchers within the trust have contacted over 1,000 patients to discuss specific studies, and this has led to 27% of that group actually consenting to take part in studies. And overall, what this means is that the people that we're now able to approach to take part in our research studies are much more representative of our population, which ultimately means the research we do will be more likely to work and be replicated in our clinical services. Next slide, please. I'd like to update you on progress with one Biomedical Research Centre supported project, which is the Oxford Brain Health Clinic. And this is a clinical service which was actually presented to you at our last AGM last year. And it's an integrated clinical and research service. So it sits within part of our memory clinic service in South Oxford. And patients who come through that are offered research assessments alongside traditional clinical assessments that we currently do in all services. And I'm pleased to say that we completed the pilot phase of this project this year. Next slide, please. I think when we started this project, one of the concerns was that if we were going to ask people to do additional assessments to hopefully improve how we form diagnoses, how we were able to offer the best treatments for people, that maybe it would be too much. We would be asking people to do too many assessments, particularly as this group of patients are exclusively over the age of 65. But what you can see from this slide is the feedback we received from patients via a questionnaire was incredibly positive. So you can see some of their comments on the right-hand side, and on the left-hand side, the two charts there demonstrate the responses that patients provided to two key questions, which is, would you be willing to complete even more assessments at your appointment if asked? And 85% said yes. And in fact, 82%, as you can see on that right-hand graph, said they would also be willing to do assessments at home after their appointment. So again, this is really just telling us that what patients think is suitable to do in their clinic appointments and what they're willing to do if it's going to ultimately improve their care. Next slide, please. What these graphs show is how many people that we asked were actually willing to do these additional tests and be contacted about future research and would allow for their data to be used to develop better services. And you can see from those lines there on the left-hand side that 92% of people asked were willing to come and do those additional research tests. 75% were happy to be contacted about other research projects, and 97% were happy for us to use their data explicitly to help use research to develop better services. And I'd really like to draw your attention to the lines on the right-hand side of this slide. And these show people that were willing to do very specific tests. So we asked people if they would be willing to have an MRI brain scan. And this is instead of the usual CT scan that is done routinely in services, and actually do a slightly longer scan in order for us to get more information that would be useful to understand their problems, and also give saliva samples for genotyping. And again, what this shows is most people were absolutely willing to do these extra tests and to do longer scans, which hopefully would ultimately help, as I said, us achieve better rates of diagnosis. Next slide, please. So as a result of these additional assessments, we've been able to do two things immediately. We've been able to reduce the time spent at follow-up appointments and also increase the confidence that we have that we've got the diagnosis correct. And this is really important in people who have very early memory problems, where maybe it's kind of difficult to tell the extent of their problem just based on memory tests. And this complicated graph on the right-hand side also shows what we were able to do with that MRI scan data. And what it shows is the blue lines at the top of the scan show normal scan data that we've taken from a UK-wide cohort that exists within the research domain. The little red dots at the bottom represent actual patients' data for people who came through the Brain Health Centre. And what this shows us is that we could identify early changes based on these brain scans that demonstrated that these particular patients' data fell outside the norm that we would expect based on their age. And this could be the only thing that actually picked up any changes for this particular patient when they presented to our Brain Health Clinic. And the video that follows after my talk will actually explain why this is so important at this point, because we're really at a time where we could be talking about delaying and potentially preventing dementia So the earlier that we can identify diseases that progress into dementia, the more likely we are to be able to make a difference. Next slide, please. So what are our goals for research in Oxford Health over the coming year? So we feel very, very strongly that research should ultimately support clinical services. I think as a researcher, I would say the reason we do all research is ultimately to improve care for our patients. And as a trust, we really want to ultimately seamlessly embed effective and sustainable research in all our services. And specifically, that means over the next year, we have 3 goals. We are going to try and develop more translational research services. So this is very similar to the Brain Health Clinic. And when I say translational services, this means research that can make a huge difference to patients very, very quickly. And we're setting up a group of clinicians across the trust to come up to identify other services that we can implement similar ideas in. You've heard from Ben Riley about the great work that's going on in our community directorate, and we're really aware that community research has been an area that's maybe been a bit ignored to date, and so we're making a very concerted effort with our community directorate colleagues to increase community research across the trust. And then, as I've mentioned, we have really key pieces of infrastructure in Oxford Health. Again, as we've mentioned, obviously we have a lot of great academic partners with Oxford Brookes University and the University of Oxford very close by. But we have, as I said, the only mental health clinical research facility in the UK, and we have a dedicated BRC that's just been renewed, again, that can help really take advantage of these national opportunities to increase research. So our third aim is to make the trust a UK hub for research so that we can bring as most effective research as possible to our patients at scale. Next slide, please. I'm going to finish off there. I know that I'm going to be able to take questions from you shortly, but we're now going to see a video which, as I've mentioned, demonstrates the huge value of the game change system, which is used in patients with psychosis who are unable to go out, enabling them to get back to their normal life by first practicing using virtual reality. And this has been developed actually now as an automated therapy guided by a virtual coach so that even more patients can benefit. And then we're going to hear from the lead researcher in this project, Professor Daniel Freeman, who discusses with Dr. Nick Broughton how it all works. And then finally, we're going to hear from one of our consultant old age psychiatrists, Lola Martos, about why the progress we're making in the Brain Health Centre is more important than ever and what we are planning for that groundbreaking service. Thank you. If we can go with the video.
When the Oxford Brain Health Centre opened, it was the first of its kind on a UK mental health trust. It was a great opportunity to bring research and memory clinics embedded under the same roof. As part of the Brain Health Centre, patients will benefit from a thorough assessment of their cognitive abilities. We are able to make earlier and more accurate diagnosis, potentially delaying and preventing the onset of the dementia. For example, by reducing and stopping your alcohol intake, increasing exercise, or even changing your diet. We are now in a position to expand to the rest of Oxfordshire and Buckinghamshire services. The challenge in the years ahead is to stay at the forefront of developing effective new treatments.
There are some fantastic psychological treatments, many of them developed in Oxford Health, but the issue is always about actually getting to people. And there's a shortage of therapists, and what we've been doing in the Trust University is using virtual reality to automate the provision of psychological therapy, so people can have a headset, take it home, and spend a lot of time with the treatment, and it's there you meet a virtual coach within VR to help people overcome their problems. And Game Change is the sort of the vanguard of this, really. It's helping people who have psychosis but have got a lot of anxiety and are often stuck inside their own homes. So we're helping them get outside by simulations of getting outside the home and into everyday situations.
Sarah, have we got a time for any questions or responses to Vanessa?
Yes, we do, David. We have got a couple of questions here. When will all patients across Oxford and Buckinghamshire be able to access the Brain Health Centre services?
Yeah, we're working on that as we speak. We have plans to expand the service across Oxfordshire and Buckinghamshire over the next year. As you can see, this is a very complex service where we're doing a lot of different assessments, which all together help us diagnose these diseases as early as we can. So they're probably going to be, the expansion will be in a stepwise process. So we're going to start with doing those additional cognitive tests first and then move on to the other assessments. But we're really hoping that we can get to the point of expanding across the Trust within the year.
Thank you. I have another couple of questions. How would one get referred to the Brain Health Centre by your GP before symptoms of dementia have started to develop?
Now, thank you, Sarah. Sorry. At the moment, because this is a new service that we're developing, and as I said, we're integrating research in it to try and assess what assessments do we need to make this service work as effectively as possible. Therefore, at the moment, we're only taking people who are referred to on memory clinics from their GPs, so people cannot self-refer. I think as the service develops, that's something that we would look at. And as Dr. Martos mentioned in the video, we know a lot about managing risk around the diseases that cause dementia now. Plus, in the next couple of years, we may well have drugs that can actually change the course of these diseases. So I really think the ability to refer yourself or to get a direct referral will come. But again, we've got to do this one step at a time.
Thank you.
That it?
I think that's it for now, David.
Right.
Thank you
very much, Vanessa. And I'm sorry I promoted you to a chair, but you deserve one. So there you are. We've had a busy evening, colleagues, and a lot of information, some fantastic presentations, some very exciting sites of what we are doing and what we might do. So thank you very much to all those who have presented to us. Thank you for your time and energy, and thank you for your attention this evening. Just two very brief reflections before we close. This commitment that Vanessa's articulated to research, to basing our practice, our medical practice, our service on evidence and sound knowledge, I hope reflects a broader culture within Oxford Health, which is that we are an open trust. This evening, I hope, demonstrates that. Next week, we have a board meeting which is open to the public. I hope members of the public, governors will attend. Governors do attend our meetings of the committees of our board, and I hope you will feel that whereas once mental health was a secluded area with walls, literal and figurative, around it, now as a mental health provider, we try to be, as we should, as open as possible about all that we do. The second point, you'll have gathered this evening from your questions and from the presentations that we do face battles, challenges ahead during the winter of this year, financial situation, pay, and then into the years ahead. It looks from Heather Smith's presentation as if, financially speaking, we're in a reasonable position, at least for the rest of 22-23, but clearly there are big issues ahead. I hope I don't sound pious, and Nick made this point earlier, to say that in fighting the good fights, and there will be fights ahead, you do have a team of executive directors, hopefully aided and challenged, as they will be on occasion, by non-executive directors who are fit for that contest. So thank you again for your attention this evening. We will have a further annual general meeting in 2023, but there will be lots of opportunities before then for us to meet each other and pick up some of the themes that we've been so richly endowed with this evening. So thank you very much for that. I wish you a very good evening and safe journeys for those who are going home. Those who are at home, enjoy the rest of the evening. Bye-bye.